Welcome to Raaonline. Today's topic is HIV in labor. According to the American College of Obstetrics and Gynaecology, pregnant women with combined antiretroviral therapy, that is called as CART, they can achieve 1 to 2% or lower risk of mother-to-child transmission if the maternal viral loads of 1000 copies per ml or less can be sustained with this ART. Plasma HIV ribonucleic acid levels in women should be monitored at the initial prenatal visit 2 to 4 weeks after initiating or changing the combined ART drug regimens, monthly until RNA levels are undetectable, and then at least every 3 months during pregnancy. Pregnant women with infected HIV whose viral loads are more than 1000 copies per ml at or near delivery, independent of antepartum antiretroviral therapy or whose levels are unknown, should be offered elective cesarean section to reduce the risk of mother-to-child transmission. Now, these patients should also receive intravenous zidovudine, ideally 3 hours preoperatively, as a 1 hour infusion loading dose, 2 mg per kg, followed by a continuous infusion over 2 hours, 1 mg per kg per hour, until delivery to achieve adequate levels of the drug in the maternal and fetal blood. This is done to minimize the chance of parent-to-child transmission of HIV. Now, if the patient has opted for vaginal delivery despite the non-suppressed viral load, then intravenous zidovudine should be initiated at the onset of labor, monitoring and continue through labor until delivery along with other drugs in their current antiretroviral regimen. Intrapartum intravenous zidovudine administration to women with RNA levels in this range is recommended as the transmission risk is slightly higher. It is approximately 1 to 2% when HIV RNA is in the range of 50 to 999 copies per ml compared to less than 50 copies per ml. So when the HIV RNA is less than 50 copies per ml, the maternal to transmission risk is lower than 1%. Whereas if the maternal RNA levels are between 50 to 999, the risk is approximately 1 to 2%. So to minimize this risk, we give intravenous zidovudine during labor. Artificial rupture of membrane for obstetrical indications can be done in HIV positive women if the patient is on ART with sustained viral suppression, though it should be used as a last alternative done due to the risk of transmission of virus due to injury of fetus during the procedure. So ARM can be done for obstetrical intervention, though it should be avoided as per ACOG. Placement of fetal scalp electrode, forceps or vacuum assisted delivery should be avoided in all HIV positive women. Though if we have to use, we will prefer forceps over vacuum because forceps is less traumatic to the fetal head and provides a protective cage to the fetal head compared to vacuum. NACO guidelines, the National AIDS Control Organization, says that the woman's serostatus should always be documented in the reproductive and child health care chart, and health workers should always check HIV status